With hypomagnesemia, hypo means lower and magnesium refers to magnesium, and emia refers to the blood. So hypermagnesemia means lower than normal magnesium levels in the blood, and symptoms typically develop at levels below 1 milliequivalent per liter. An average adult has about 25 grams of magnesium in their body. About half is stored in the bones, and most of the other half is found within cells. In fact, magnesium is a really common positively charged ion found within the cell, second only to potassium. A very tiny fraction, roughly 1% of the total magnesium in the body, is in the extracellular space, which includes both the intravascular space, the blood vessels and lymphatic vessels, and the interstitial space, the space between cells. About 20% of the magnesium in the extracellular space, which would be about 0.2% of total magnesium, is bound in negatively charged proteins like albumin, but the other 80% or 0.8% of total magnesium can be filtered into the kidneys. So inside the kidney, that magnesium gets filtered into the nephron, and about 30% gets reabsorbed at the proximal convoluted tubule, 60% gets reabsorbed in the ascending loop of Henle, and 5% gets reabsorbed at the distal convoluted tubule. And that leaves only about 5% to get excreted in the urine. Magnesium levels can fall in a few situations. One scenario is when the nephron fails to reabsorb the magnesium that's filtered out of the blood, which would mean more gets excreted in the urine instead of kept in the blood. Magnesium reabsorption is mostly a passive process, where the positively charged magnesium ion follows the electrochemical gradient and moves from the positively charged lumen into the cells lining the lumen, which usually have a negative charge. Now, loop and thiazide diuretics can disrupt this process, because they both make the lumen less positively charged, and this diminishes magnesium's electrochemical gradient and causes more of the ions to stick around in the filtrate and get peed out. Another sort of similar scenario is a genetic mutation that affects the channels that regulate ion flow, which again could change the electrochemical gradient and cause more magnesium to stick around in the lumen and get peed out. An example of this is Gittleman syndrome, where there's a mutation in the gene coding for the NaCl cotransporters in the distal tubule. Now, a different mechanism for hypomagnesemia is prolonged malnutrition, where not enough magnesium gets consumed. Alternatively, there might be enough consumed, but not enough absorbed in the gastrointestinal tract. So instead of going into the blood, it gets excreted. And this can happen because of interference from medications like proton pump inhibitors, or from a bout of diarrhea. Another cause of hypomagnesemia includes uncontrolled diabetes mellitus, where sometimes there can be increased levels of glucose in the blood. And this means that there's also increased glucose filtered into the kidney and nephron, which ends up attracting a lot of water and causes a large volume of urine to flow through the nephrons. This high urinary flow carries ions like magnesium right through the nephron, because the fast flow doesn't allow enough time for magnesium reabsorption to happen. Yet another cause is hungry bone syndrome, which is when the thyroid or parathyroid glands are surgically removed, which leads to increased bone formation. In this case, the osteoblasts, or bone-forming cells, are literally hungry for ions to make more mineralized matrix, and so it ends up taking the magnesium from the blood. Another one is alcoholism, which offers kind of a mixed picture, because often these individuals have a poor diet, which means there might be low magnesium intake. But in addition, alcohol also increases renal excretion of magnesium,